Hello, 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 hello. Can you guys hear me? Okay, I hope every one of you is doing good. And we are going to start from where we left. Okay. So before I start, anybody have any question, any confusion? Any question, any confusion? All good? So did you guys receive the recordings? All recordings? Yes or no? Okay.
Yeah, we received the recordings.
Thank you. Thank you.
Just the two were missing, Doctor, the one you said.
Yeah,
Those were the ones.
thank you for much. Thank you so much for responding. Okay.
Mm.
Okay. So two I told you because they were not recorded in my computer because of some technical error. The rest of all you guys have received. And hopefully you will receive every recording from today and onwards. Okay. And I'm sorry for any inconvenience. Okay. All right. So we completed the torsion. Now let's do varicocele. And today we have to do the breast as well and complete your Repro. Varicocele. Is it? So varicocele is there. All right, so varicocele. Now, varicocele is defined as what's the definition of varicocele? Is a dilation of veins within your testes, dilation of the veins. So it's called the dilation of the pampaniform plexus of the veins. Dilation of pampaniform, pampani, pampaniform plexus. Pampaniform plexus is it's a collection of the venous plexus in the testes, in the scrotum. Okay, pampaniform plexus. Okay, and that will actually leads to what? If you get the distension of the veins in the scrotum, that will lead to the scrotal enlargement. You're going to get the scrotal enlargement being there. Okay, scrotal enlargement. So, can anybody tell me what's the most common cause of varicocele? Why do we get the varicocele? Yep. What's a cause of varicocele? Yep. Mm-hmm. What's a cause or risk factor for varicocele? Yep. Anyone? It's most likely due to the blockage of the veins. It's what do you mean by the rapid weight loss? Okay. So it's not a rapid weight loss. So my question is that what's the cause of your varicocele? The cause of varicocele is a blockage of the veins. When you get the blockage of venous drainage. So when you get blockage of venous drainage, what will happen? The blood will accumulate within the veins, which will lead to the venodilation. Is it blockage of venous venous drainage? When your veins are blocked, you're going to get what? Varicocele, blockage of venous drainage. Now, varicocele is very common on the left side of the testes. Why? What's the reason? Why it is very common on the left side of the testes? Because your left gonadal veins or left testicular vein drain into the left renal vein. And the pressure in the left renal vein is more compared to the inferior vena cava. So it's very commonly seen on the left-sided. Left-sided varicocele is very common. Left-sided varicocele. Because this as I already discussed with you guys, left gonadal vein is going to drain into the left renal vein, is it? And then your left renal vein will drain into the IVC. Why left renal vein doesn't drain directly into the IVC? Anyone? What's the reason? Yep. What's the reason? Why
The
does the
flow
left?
distance.
Yep. Because IVC is on the right side and the left gonadal vein is on the left side. Is it? So this is the reason first it have to drain to the left renal vein, then it will go into the IVC. Now, what is the most common cause of your varicocele? It could be your renal cell cancer. Renal cell cancer, which is compressing your left renal vein, and then it will compress your IVC. So renal cell cancer can lead to your renal cell cancer. Uh, and we already discussed this renal cell cancer, which is called clear cell cancer. that can invade your left renal vein, and then it will invade your IVCs. Is it? So that will actually lead to the varicocele. It can lead to both. So left renal cell cancer can lead to the both-sided varicocele, right-sided and the left-sided both. Is it? All right. So this is the most common cause of your varicocele we see. Now, what will be the symptoms of varicocele? Anyone who wants to voluntarily tell me the symptoms of varicocele? If any patient who get the distension of veins in the testes, what will be the presentation? Mhm. Yep, yep. So you will get what? Testicular, testicular swelling, testicular enlargement, or testicular swelling that will increase with the what maneuver? Testicular swelling, swelling which increases with what? Swelling which is going to increase with the when a patient stands up. When a patient stands up, the swelling will increase. Can anybody tell me why? Why this maneuver will increase the swelling? That's a very important point to know. When patient stands up, the swelling will increase. This is a one maneuver.
Because of gravity.
Excellent, very good iPhone. Because of gravity, the blood will pool within the veins. It will go in the downward direction. So because of gravity and other maneuver which will increase the swelling is called Valsalva. Because Valsalva is going to increase the abdominal pressure, which is going to lead to more compression of IVCs, and you will get what? This swelling will increase, is it? So distension or expansion, and this will be the one characteristic of swelling. And what's the other characteristic of swelling? What will be the you will feel the bag of warm when you actually palpate or when you actually palpate the area of the swelling. It will have the feelings of bag of warm palpation, bag of warm palpation, bag of worms. It looks like a worm because the venous swelling be there. So this is a typical characteristic of your swelling. Now, third characteristic of swelling will be what? It will never trans-eliminate. Why it will not never why it will not trans-eliminate? The reason is that because it's not a clear fluid. The light will trans-eliminate through a clear fluid. Is it? So these will be the typical feature of your testicular swelling that is called varicocele. Now, can anybody tell me the complication of varicocele? What's a complication of varicocele? So that will be the presentation. Now, what's a complication of varicocele? Mhm. Varicocele,
Subfertility,
it will lead
subfertility or
to infertility,
infertility in the
infertility, not subfertility, infertility. The reason because varicocele will lead to increased temperature in the testes because blood carries a lot of the heat. So it will actually lead to infertility because of increased temperature of the testes. Get it? All right, so that's a very important complication to know. Okay, now how do you diagnose the varicocele? What investigation you will do to make a diagnosis of varicocele? Yep, investigation of choice. Yeah,
ultrasound.
ultrasound of the testes. Very good. Ultrasound. Oh, excellent. So you do the ultrasound, and the ultrasound is going to show us the venous dilation will be there. Okay. And once you make a diagnosis with the ultrasound, now you have to treat it. Treatment. Yep. So treatment means you have to, you know, remove the blood out of the testes. So how you're going to do it? You are going to do the, I mean, surgical ligation could be there, or you will do the embolization. Embolization can be seen if it is associated with severe pain. So surgery is an option for this varicocele. Surgery, or you will do the embolization of the veins if it is associated with the severe pain and infertility in the patients. Okay, so that was all about the varicocele for you. Now we are going to discuss another swelling of the testes, which is called hydrocele. Hydrocele, hydro, as the name suggests, hydrocele, hydrocele. So, what is the definition of hydrocele? Hydrocele means the accumulation of clear fluid within the scrotum is called hydrocele. Simply accumulation of the clear fluid within scrotal tunica vaginalis layer. Okay, accumulation. It's just a peritoneal fluid. Simply, I will say accumulation of peritoneal fluid in the tunica vaginalis of the testes. Accumulation of clear fluid, clear fluid clear fluid in the tunica vaginalis, in the tunica vaginalis of the testes. Now, can anybody tell me what's the cause of the hydrocele? You know, in order to understand the cause of hydrocele, there are two types of the hydroceles being there. One is called communicating hydrocele and is called non-communicating hydroceles. So communicating means it is still in communication with the peritoneal cavity. The fluid is coming from the peritoneal cavity. So communicating hydrocele means it's due to the failure of your processus vaginalis to close. You know, processus vaginalis is exactly what? Processus vaginalis is a fold of peritoneum which facilitates the descent of the testes from abdomen to the scrotum. Is it? So once the testicular descent is completed, normally this processus vaginalis should close. Processus vaginalis should close. If it doesn't close, what will happen? Your peritoneal cavity will be in direct communication with the scrotum. Okay, so process vaginalis does not close. Does not close. That will lead to the communicating hydrocephalus. Communicating hydrocele. Communicating hydrocele is there. Now, this communicating hydrocele is very commonly seen in the infants, in the children's, in the newborns or in the children's. So it will present as a testicular swelling in your infant. Simply testicular swelling in your infant is called your communicating hydrocephalus. Now, can anybody tell me communicating hydrocele is associated with what other finding? Will be seen, it will be present. How it will present? It will present as the testicular swelling, testicular swelling. And obviously, this testicular swelling will what? It will trans-illuminate. It will trans-illuminate because it is a clear fluid. Okay, so testicular swelling which trans-illuminate on the light examination, that is called your hydrocele, but it is actually communicating hydrocele. So testicular swelling in the infants. Now, what other finding you will see with the communicating hydrocephalus? Sorry, hydrocele. I always call it
Inguinal hernia.
Indirect inguinal hernia.
very good. Indirect inguinal hernia because there's an open communication being there. So it will allow the abdominal viscera to come from the deep inguinal ring, then from the superficial inguinal ring. So it's always associated with indirect inguinal hernia. And I will discuss these types of hernia in the GI with you guys. Indirect inguinal hernia. Okay, that will be the association of your communicating hydrocele. Now you can get the non-communicating hydrocele. So what could be the what is the cause of non-communicating hydrocele? Anyone? Non-communicating means your processes vaginalis is actually closed. So before going into the non-communicating, how will you treat the communicating hydrocele? Treatment. Will you do any surgery for it?
Mostly it
No,
resolve by itself.
self-resolve.
Yes, most of the time it's self-resolving. So you have to wait for up to 1 year. If it doesn't resolve, then you have to do the surgery. Otherwise, it will self-resolve. It's going to self-resolve. Self-resolve. Okay, it's going to self-resolve. Get it? Now we have your acquired one. So communicating was congenital one. Now acquired one means it's an environmental one. So what environmental pathology can leads to the hydrocele? It will be most commonly due to trauma to the testes. When you get trauma to the testes, it will lead to fluid accumulation within the testes. The trauma is the most common cause here. Could be trauma, or you might get infection, which will lead to inflammatory fluids being there, inflammatory fluid accumulation. And other cause could be your tumor producing a lot of the fluid. So that will be the acquired cause. Is it? Now in this scenario, you can get the accumulation of the clear fluid, but you can also get the accumulation of blood in the scrotum. So when you get the accumulation of blood in the scrotum, what is the name of that disorder? It will be called hydrocele, or its name will be changed.
Hematocele.
Excellent, very good. Hematocele is actually very good. So this is going to be the hematocele, and still it's a blood, so it will actually trans elimination will be positive here. Is it? So that will also trans eliminate being there. All right. So these are the causes of your hydrocele and the types of hydrocele. Now there's a one other testicular swelling which is not a hydrocele, which is not a hematocele, but it is still trans-eliminate. What's the name of that? That is called spermatocele. So now I'm going to discuss spermatocele. Very good, L. Excellent. So spermatocele is there. Spermatocele. Spermatocele. Okay. So spermatocele is exactly what? Spermatocele is defined as what? So spermatocele means some sperms, your sperms are getting accumulated, is it? So you get what? Dilation of epididymitous, dilation of the epididymitous duct or reti testis. So this is actually due to the accumulation of sperms, accumulation, accumulation. Simply, I would say accumulation of seminiferous tubule. Oh, sorry, semen. Accumulation of semen within epididymitis. 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 Okay. Epididymitis duct. Okay, so you guys must be thinking, what's the reason? Why does, these accumulation happens? Why the semen is getting accumulated in the epididymitis? The reason, it could be the blockage of vas deferens, or you might get the absence of vas deferens. Who carries the sperm from epididymitis to the urethra? It's your vas deferens, is it? These are the tubes. So you might get, if you get the blockage of your vas deferens, it will lead to spermatocele. Spermatocele is an accumulation of your semen within the epididymitis or reti testes. Now, your epididymitis is, what is the location of epididymitis? It's located it's located on the sides of the testes. So if it is located on the sides of testes, so how will the spermatocele present? Spermatocele is going to present its paratesticular episodic swelling, not a continuous swelling. Can anybody tell me why? Why it is presenting as a paratesticular episodic swelling? Paratesticular episodic swelling. Why episodic? Because whenever semen production increases, the swelling will increase. And if there's no semen production, the swelling will reduce. It's called fluctuant swelling. Fluctuant, is it? Fluctuant. All right. And this will also trans-eliminate because semen is a clear fluid. Semen is a clear fluid, so this is going to trans-eliminate. Okay. So these were all your testicular swelling and the testicular disorders. All right. Now we have another disorder which is called the squamous cell cancer of the penis. Okay, so this is a squamous cell cancer of the penis. We are going to discuss now squamous cell cancer, cell cancer of penis. Okay. So squamous cell cancer of the penis, penis is being lined by the squamous cell, so that's the reason it has a squamous cell cancer being there. Now, before the squamous cell cancer of the penis arises, there are some, precursor lesions which will lead to the cancer. So, what are these precursor lesions? Precursor lesion first is actually called your, Bowen disease. Bowen disease. Bowen disease. So, what is actually Bowen disease? Bowen disease is actually going to present as your leukoplakia. It will produce the white plaque on the penis, and it's very commonly seen on the penile shaft. Penile shaft is there. Penile shaft. Penile shaft. Penile shaft, which will produce the white lesion, leukoplakia. Now, you guys must be thinking, what's a risk factor for Bowen disease? What's the cause of Bowen disease? Anyone who knows the cause of Bowen disease? Why do I get the Bowen disease? Mm-hmm. Yep. The most common cause risk factor is actually your infections, HPV. HPV is in fact HPV is the risk factor, HPV 16 and the 18, and no circumcision. Circumcision is a protective factor here. So males who are not circumscribed, they do have the risk of getting the Bowen's disease. Is it? So one is called Bowen's disease. Another, the precursor lesion is called the erythroplakia of Kuwait. Erythroplakia. So if it is a erythroplakia, it will produce what lesion? Erythroplakia, as the name suggests. Erythro means what? Erythro. Yep. Very good. Say loudly. You're right.
Red.
Red lesions. Very good. Sony, say loudly. Very good. Very good. Erythroplakia of Kureth. Okay. So you get erythroplasia of the Kureth. That's also precursor lesion, and this is very commonly seen in the glans penis. Glans penis, okay, glans of the penis, and it's going to present as a red plaque, not a white but red plaque. Red plaque. Get it? So this is a second precursor lesion which will lead to squamous cell cancer, and the third precursor lesion is called bovenite plaques. Bovenite. Bovenite plaque. Okay, so bovenite plaque is going to do what? It's going to present as it's going to present as reddish papules as well. Small reddish papules being there. Okay, reddish papule. And risk factor for all of these all of the three precursor lesion is actually what? Is an infection with the HPV 16. Okay, so when you get infection with HPV 16, HPV 16, HPV 16, 18, or and your uncircumcision, no circumcision is a risk factor for them. Okay. All right. So, penile cancer is actually common in the Asian countries, not that much common. Okay. It's not that much common in the, America, but it's very common in the Asian countries being there. All right. So that was all about your penile cancer. Get it? All right, so now we're going to discuss the other disorder, which is called your PPH and the prostatitis and the epididymis. So let's discuss the epididymitis, and your prostatitis or chitis, is it? So let's discuss the inflammation of epididymitis. 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 Okay. So epididymitis is actually called as the inflammation of epididymitis. Epididymitis is called your epididymitis, is it? So, what is the most common cause of epididymitis? Why do we get the epididymitis? Depending upon the age of the patient. If patient is actually young male, if he's a young male, what bacteria are very common in the young males? They will be sexually transmitted infection. So two bacteria are there which will lead to epididymitis. One is called your gonococci, Neisseria gonorrhea, and other will be called your chlamydia trachomatis. Okay. Gonorrhea and the chlamydia trachomatis, they are very common in the your young males. Now, what about the older males? Can anybody tell me what bacteria is the most common cause of epididymitis in the older males?
E. coli
E. coli,
Very good. E.
and
coli.
Pseudomonas, I think.
E. coli. Very good. E. coli and Pseudomonas. Excellent. E. coli is there. E. coli and Pseudomonas. Very good. So these are the two bacteria which are the most common cause of epididymitis. So this is called your infective epididymitis. Now you might get the autoimmune reaction to the epididymitis, which can also cause the inflammation. So any patient who get the epididymitis, how it is going to present symptoms? Very important to know these symptoms. Symptoms of epididymitis. Epididymitis is located on the posterior side of the testes. Okay, so it's going to present as you know, tenderness over the posterior testes. You will get what? Tenderness over the posterior testes. Tenderness over the posterior testes, that's going to be your first symptom, and it will also lead to the pain. Localized pain will be there, severe pain will be there at the posterior side of the testes. Localized pain means posterior side pain, so testicular pain is going to be there. Now, very important to know, physical examination finding. On physical examination finding, the one test will be positive. That is called your Farron sign. Farron sign is going to be there. So can anybody define Farron sign for me? That's a unique finding of the epididymitis. Farron sign means what? When you actually elevate the scrotum, elevation of scrotum will lead to the relief of the pain. Can anybody tell me why? Why scrotal elevation? When I do scrotal elevation will lead to relief of the pain. Relief of pain. Okay. What's the reason? When I do scrotal elevation, how it will lead to relief of the pain? Uh-huh.
Because we decrease tension on the epididymal structures, right?
Very good. So when you actually elevate the scrotum, you are actually moving the inflammatory fluid up. You're moving the inflammatory fluids up, so that's going to relieve your pain. Very good. So a scrotal elevation is going to lead to your, all right. So that will be your, typical sign that's called Farron sign. So what sign was actually absent in the torsion, testicular torsion? What reflex was absent? Yesterday we discussed that. Your cremasteric reflex. Cremasteric reflex will be absent in the testicular torsion. All right, so that will be the physical examination finding. Now, what's the complication of epididymitis? Complication. Yep, complication. What is the complication of epididymitis? Mhm. The complication of epididymitis will be. Hello, hello. Sorry. Okay. Sorry, I get disconnected. I don't know why. Okay, so we were discussing the epididymitis, and I was asking a question, what's the complication of epididymitis? Yep. What is the complication?
Infertility.
Yes, it will actually lead to testicular inflammation. It can cause orchitis. It can cause orchitis. Once your inflammation extends into testes, it will cause orchitis. Now, treatment. How do we treat the epididymitis? Treatment.
Treat the infection cause.
Very good. Use antibiotic. Antibiotic. Okay. Antibiotic is a treatment of the choice. Got it. Very good. So now we are going to discuss orchitis, which is actually the inflammation of the testes. Orchitis. Orchitis. Orchitis is defined as what? Orchitis is defined as your inflammation of the testes. So what is the cause of orchitis? Anyone who knows the answer? What are the cause of orchitis?
Mumps.
Yep.
Mumps. Bhai.
Excellent. Very good. Mumps infection, inflammation of testes. Mumps can cause orchitis. Mumps can cause parotitis. Mumps can cause pancreatitis. Is it inflammation? So one cause is actually your mumps. What are the other cause? Yep. Mm-hmm. Mumps. And other cause, which is most common, is called autoimmune orchitis or autoimmune disease. Is it? So when you get autoimmune disease, it will attack your seminiferous tubules of the testes, which will lead to granuloma formation. You will get the granulomas within the seminiferous tubules. Get it? So any patient who get the orchitis, how it is going to present symptoms? Symptoms of orchitis. Yep. Symptoms of orchitis will obviously
Testicular pain.
signs of inflammation. It's going to lead to your testicular swelling, testicular pain, pain and the swelling, pain and the swelling. Yep, pain and swelling. And the complication will be obviously your infertility. It will actually infertility will be there. Okay, mumps, or especially mumps or orchitis is going to lead to inflammation. Your I would say that.
I'll be back in 5 minutes.
Okay. All right. So
I'll
that.
be back in 5 minutes.
You what?
Okay.
Look, I'll be back in 5 minutes.
All right, so that will be your orchitis for you. Now let's discuss other male disorder, which is called your, I would say you know, prostatitis. Let's discuss the prostate inflammation, then we discuss the BPH. Prostatitis. Okay, prostatitis. So prostatitis is defined as what? inflammation of the prostate is called prostatitis, inflammation. So there are two types of the prostatitis we get. One is called acute prostatitis and is called chronic prostatitis. So let's discuss the acute one. Acute means you will get the rapid onset of the symptoms. After the process begin, you are going to get the rapid onset of the symptoms that's called acute one within 2 weeks of the infection. Within 2 weeks of the infection, that will be called acute one. Now, this acute prostatitis, what's the most common cause of acute prostatitis in young males? If it is young male, what will be the bacteria? Young males. Again,
Chlamydia.
gonococci and the chlamydia.
Same.
Gonococci and the
Yes.
chlamydia. So, chlamydia, trichomonas, and gonococci. Trichomonas plus gonococci. They are the most common cause of acute prostatitis we see in the young males. And if it's the older male, again, E. coli is most common. Older male. E. coli is there. Get it? So E. coli is going to cause the infection in the older males. Now, if any patient who get acute prostatitis, you know how he's going to present symptoms. So what is the symptom of prostatitis? When you get inflammation of prostate, it's going to cause what? It's going to irritate your urethra. Once if it irritate your urethra, what symptoms you will get if it irritate the urethra? Yes, if your urethra is irritated, obviously you are going to
Urgency,
I did.
frequency.
very good dysuria, urgency, and frequency. So that will be the due to irritation of urethra, urgency and the frequency. Got it? All right. Now, what will be the physical examination finding in case of prostatitis? Physical examination finding. Physical exam. Yes, so physical examination is going to show us the warm, tender prostate. You're going to get the warm, tender prostate. Get it? Warm, tender prostate is going to be seen on the physical examination. Now, how do we treat them? We give them the antibiotics. So, what antibiotic covers the gonococci? So that here I want to test you guys. I didn't ask the antibiotic earlier.
Doxycycline.
I say for gonococci. Doxy for the chlamydia, you're right. Doxy for chlamydia. But for gonococci,
Clindamycin. Don't
now,
remember.
now, ceftriaxone. Ceftriaxone.
Ah,
Okay.
yes, yes. Ceftriaxone.
Ceftriaxone.
Thank you.
No problem, anytime. Okay. All right. So this is actually your acute prostatitis. Now, what is the complication of acute prostatitis? The complication of acute prostatitis will be chronic prostatitis. Chronic. It can lead to chronic one. If you get the repeated episodes of acute or you don't treat the acute prostatitis, it's going to become a chronic one. Okay, so chronic most likely due to bacterial one, or it could be due to non-bacterial causes. So what are the non-bacterial causes which can lead to chronic prostatitis? Non-bacterial causes. Mhm. It could be due to some chemical irritations. Chemical irritations are there. Chemical irritations. It's due to chemical irritations being there, okay, or any some nerve problem which leads to retention of urine that will lead to the chronic prostatitis, and chronic prostatitis doesn't produce much symptoms. Okay. Now we're going to jump into your BPH, which is very important to know, benign prostatic hyperplasia. BPH. So BPH is defined as the hyperplasia. It's actually increased number of the cells within your prostate gland that leads to increased size of the prostate. So BPH is defined. How do you define the BPH? BPH is defined as the smooth elastic enlargement of the prostate. It's defined as a smooth elastic, smooth elastic enlargement. Okay, enlargement of prostate. Okay, smooth elastic enlargement of prostate is called BPH, and which is due to increased number of the glands. Hello, hello. Sorry, I don't know why I'm getting the multiple problems with the internet. I'm sorry for any inconvenience. Okay, so let's resume. We were discussing the BPH. Okay, so let's do the BPH. So BPH is defined as a smooth enlargement of the prostate. Smooth enlargement of prostate due to increase in the number of the glands of the prostate. Increase number of glands. Increased number of glands of prostate. Now, prostate gland has a three zones being there. It is a three zone. So suppose this is my prostate gland. This is my prostate. Now it has the three zones being there. The area which is actually, this is called central zone of the prostate. Now this is blue one is called peripheral zone of the prostate. This is called peripheral zone. This is called peripheral zone. Now region which is present in between the central is actually green. Central one is green. This is central. And blue one is called your peripheral. This is called peripheral. Peripheral. Now the region which is brown color, which is in the middle. This is being present between central and the peripheral zone. What's the name of this zone? This zone is called transition zone because you are just transitioning from the central to the periphery. This is called transition zone. And from this transition zone, I would say, urethra passes very close to the transition zone. So urethra is actually passing through this region. This will be urethra passing. So urethra is passing. Now, BPH is very commonly seen in the transition zone. The most common side of the BPH is actually transition zone, is it? That's the location. Now, you guys must be thinking, what's the cause of BPH? What's the cause of BPH? Why do we get the BPH? Anyone? So, side location is what? Location is actually transition zone. So, from peripheral zone, what pathology arises from peripheral zone? Peripheral zone is a location of prostatic cancer,
Cancer.
prostatic adenocarcinoma. Peripheral zone, from the peripheral zone, you will get what? Prostatic adenocarcinoma. Prostatic adenocarcinoma comes from peripheral zone, which is very close to what? Peripheral zone of the prostate is very close to what structure? Anyone? Yep. Peripheral zone of the prostate is very close to what? Yep. It's very close to the rectum.
Central, you mean? Or
Very close to the rectum. It makes sense, is it? So blue zone is very close to the rectum. It's very close to rectum. So what is the cause of your, BPH? I mean, it's age related. It's age related. Aging is the number one risk factor. Aging. So increased age is a risk factor here. When you get increased age, with the increased aging, male greater than 50 is a risk factor here. Increased age. Age is a risk factor. Okay. So how does the BPH present? Symptoms of the BPH. So look at this. BPH is actually originating from transition zone, which is very close to the urethra. This is my urethra.
causes urinary obstruction.
Very good. It will actually come.
But prostatic cancer doesn't cause that.
Yeah, very good. So because prostatic cancer comes from the peripheral zone, which is far away from the urethra. So BPH is going to do what? It is going to compress the urethra into small space, vertical slit space. So it's going to compress the urethra. If it compresses the urethra, you are going to get the urinary symptoms. So what urinary symptom you are going to get? You will have the increased frequency of urination. Increased frequency. Urination. Okay. Because urinary retention will be there. Dysuria is going to be there. Very good. And what else? Which is the typical finding here? Frequency.
Weak stream.
retention,
I mean, we see frequency, dysuria, urgency in every disease, but typical finding.
Weak stream.
Weak
weak stream,
Very good. And
And incomplete emptying.
incomplete emptying, and you will get difficulty starting and stopping the urination. Difficulty starting and stopping the urination. That's a typical finding of the BPH we will see. Get it? All right. So that will be the typical symptoms of your benign prostatic hyperplasia. Now, what will be the complications of BPH? Complication. Yep.
Retention, urinary retention, and hydronephrosis.
Yes, so it's going to lead to your, hydronephrosis. And hydronephrosis will be what? Bilateral or unilateral?
Bilateral.
Excellent. Bilateral. Very good. Hypertrophy of bladder. Very good. Hydronephrosis. And what kind of the urinary incontinence we will see in a BPH patient? Urgency, frequency, urgency, sorry. Other is called stress, and third is called your overflow.
Overflow
It
incontinence.
also leads to overflow incontinence. Overflow incontinence. Overflow incontinence. Very good. All right, so that will be your BPH one. All right, and BPH will also obviously increase the risk of UTIs, urinary tract infection. UTI risk is very high with the BPH. Get it? So how do we diagnose the BPH? What lab investigation we will do to make the diagnosis of BPH? Yep. So we will measure the marker for the BPH, which is called your PSA, prostate specific antigen, PSA. Now PSA, is equals to what? Total PSA is equals to what? Is equals to your bound PSA. Bound. This is very important to understand. Bound PSA, which is bound to some proteins, plus free PSA. Free PSA. So BPH will increase what? BPH will increase the bound PSA or free PSA. That's important to know.
Free PSA.
Excellent. It will increase the free PSA and it will increase the total PSA, but bound PSA is going to remain same. Very important to know because your cancer will likely decrease the free PSA, increase the bound one. Is it? So I'm going to discuss that. All right. So this will be elevated in the patient. That makes the diagnosis of the BPH. Get it? Now you have to treat the BPH. In order to treat the BPH, you have to treat the urinary symptoms plus decrease the growth of your prostatic gland. So how you're going to treat the BPH? You have to first relieve the urinary symptoms. So you have to use the muscle relaxants, and you have to relax the prostatic gland. So you will give alpha 1 blocker drugs, alpha 1 antagonist, alpha 1 antagonist. And these alpha 1 antagonist which we are going to use, it will be called as your tamsulosin. So we will use tamsulosin if patient's blood pressure is normal, only he has the symptoms of your BPH. Then use the tamsulosin. Now, what alpha blocker you will use if patient is having the high blood pressure plus BPH symptom at the same time? Yep,
Tarazosin.
parazosins, excellent, parazosins. Because parazosin can block the alpha receptors on the blood vessels as well. Parazosin, terazosin, they do have the alpha blockage action on the blood vessels, whereas tamsulosin only block the alpha receptor on the prostate, on the prostate. Get it? So, all right, so that will be the one. Now, what other medications you will use to actually, do the relaxation of the muscles? I mean, relieve the obstruction. You will use the phosphodiesterase inhibitors as well. PD inhibitors, phosphodiesterase. I'm coming to the fenestrate, but here we use your PD phosphodiesterase 5 inhibitor, okay, which is called sildenafil, tadalafils. We can use that. So these are for the symptomatic improvement, but which medication is going to decrease the growth of the prostate? It will be called as your fenestrate, 5 alpha reductase inhibitor. So when will you use a 5 alpha reductase inhibitor? It will actually reduce the growth of the prostate, 5-alpha reductase. It will do what? It will reduce the growth of the prostate. Prostate. Get it? So this is the one medication which will decrease the growth of the prostate. Can anybody tell me the name of other medication which we use to decrease the growth of the prostate? What's the name of that? Mhm. Yep, that will be called leuprolide, GnRH agonist. So you use the continuous leuprolide, which will actually do what? Continuous leuprolide is going to downregulate the your GnRH receptor, leuprolide. Get it? All right. So this will be the management. If the patient does not show improvement in the symptoms while taking these medication, then what is your next best step? Yep. A patient
Surgery,
surgery. What's the name of that surgery? Very good.
prostate-
Trans
prostatectomy,
transurethral radical prostatectomy, TRUP. Okay. All right. If it is not successful, then we do the ablations, electroablations. All right. So that was all about your BPH. Now let's discuss the prostatic adenocarcinoma. Prostatic adenocarcinomas. Okay. Prostatic adenocarcinomas. Prostatic adenocarcinoma. Prostatic adenocarcinoma. Why it is called prostatic adenocarcinoma? Because prostate is a gland, so that's the reason it's called prostatic adenocarcinoma. Now, the cancer which arises from the prostate gland is called prostatic adenocarcinoma, and it's most commonly seen in the patient greater than 50 years. Remember, I yesterday told you already, BPH will never convert into adenocarcinoma, prostatic adenocarcinoma. BPH will always remain as the BPH, is it? So this prostate adenocarcinoma is coming from the separate pathway. It's very commonly seen in the greater than 50 years male. Okay. And do you know what is the most common location? I already told you it's coming from your peripheral zone, posterior peripheral zone. Peripheral zone, which is called the posterior lobe of the prostate. Okay, so if it is coming from the posterior lobe, it means your prostatic adenocarcinoma is going to be do what? It is easily palpable with the digital rectal examination. So when we do the digital rectal examination, because peripheral zone is very close to the rectum, is it? It's very close to the rectum, which is also called the posterior lobe. All right. Now, this prostatic cancer is there, so you get the proliferation of prostatic adenoma, prostatic glands without the proliferation of the stroma being there because the cancer being there. Is it? So how does the prostatic cancer actually present? What's the symptoms produced by the prostatic gland cancer? Yep. Mhm. What are the symptoms produced by the prostatic cancer? Uh-huh. So prostatic cancer is usually asymptomatic. It doesn't produce the symptoms until and unless it get metastasized. So where does the prostatic cancer metastasize?
Bone.
Bone.
Very good. It goes to the bones. That will be the backbone, vertebral bones, lumbar bones, vertebral bone or spine. Very good. Spine or vertebrae. Now, when it metastasizes to the bones, it will lead in the bones. It will lead to what? It will increase the activity of osteoblast or osteoclast cell.
Plastic activity increases.
Very good. It will increase the osteoblastic activity. So it's going to lead to the formation of bone, which is going to compress your spinal cord. So osteoblastic activity is increased, is it? Now, how does the prostatic cancer metastasize to the vertebrae? Through lymphatics or through blood? Uh-huh. It's going to go to the vertebrae through blood, and that these are called your Batson venous plexus. Batson venous plexus. These are called Batson venous plexus. Okay, so these venous plexus actually normally drains your vertebrae. Normally drains your vertebrae, so it goes there. Now, if your prostate cancer goes to the back, it will present as a severe back pain, and that back pain will be very severe in the morning or at the night time. So it's going to present a back pain. That back pain is going to be severe in the morning or at the night time. Yep, it's going to be very severe at the night time. Can anybody tell me the reason why the cancer pain, any cancer pain, any cancer pain is very severe at the night time. Why? Because cancer produces a lot of the inflammation in the body, a lot of the inflammation. And at the night time, inflammation is very high. The reason is that at the night, your cortisol goes down. So if your cortisol goes down, your inflammation will increase, is it? So this is the reason it will present as a severe back pain, and the patient will say that this severe back pain interfere with his sleep. It interfere with his sleep. Okay, so this is actually called your, symptoms of prostate cancer. Now we have to, in order to determine the prognosis of your prostate cancer, we will use what grading system or your staging system. Yep.
Grading.
Excellent. What type of grading we use? Very good. That's called Glinson grading. Glinson. Glinson grading system. Glinson grade. Now this Glinson grade will actually, will measure what properties of cancer is going to, its score depends upon the morphology of the glands, the architecture of the glands. So if the architecture of gland is, is completely distorted, or is completely different from the normal prostate gland, it will be cause high Gleason grade. And okay, so it looks for the architecture, glandular architecture. So glandular architecture, if it is completely distorted, it will be called high grade Gleason. And high grade Gleason grade have the highest metastatic potential. So metastatic potential depends upon the architecture of the glands, is it? So tumor which is actually high grade, it will have what? More metastatic potential, is it? More metastatic potential. Okay, more metastatic potential is going to be there. Get it? All right, so now in order to diagnose the prostate cancer, we will do what? We will do the imaging plus your, lab diagnosis and the biopsies. So what lab analysis you will see? What lab you will do? What labs we perform to actually diagnose the BPH? Yep. So we measured the PSA, prostate specific antigen. So in the prostatic cancer, what form of the PSA will be increased? Bound form or free form? So here your bound form will be increased. Bound PSA is increased because prostatic cancer produces a lot of the proteins which will actually combine with the PSA, and it will lead to reduced free form because all the free PSA will be converted to the bound form. Get it? So you get what? Increased bound form of the PSA. That will increase the total PSA. This is the one marker. Another marker is there which is also positive in the prostatic cancer. And what's the name of that? That is called prostatic acid phosphatase. Prostatic acid phosphatase. Okay. That's going to be positive here as well. Prostatic acid phosphatase. Get it? All right. So that's actually your, all right. So what other serum marker is going to be elevated in the prostate cancer if your prostate cancer metastasize? If it metastasize, excellent, very good. Serum ALB. What's the reason? Alkaline phosphatase. Because increased alkaline phosphatase indicates more activity of osteoblastic cells. So serum ALP is going to be elevated as well. Okay. Now, if these lab tests are positive, then what will you do? You are going to do the subsequent needle core biopsies. You have to take out the multiple biopsies of the prostate gland, and through what route you will do the biopsy? Yep.
Transrectal.
Very good. Excellent. Very good. So you are going to follow the transrectal ultrasound guided biopsies, transrectal. And why do you do a multiple biopsies, multiple needle core biopsies? Why not single? Yep.
We can miss the
Excellent.
But
Very good.
yes, sir.
Very good. Very good. So you do this multiple needle core biopsies. And why? Because if I'm doing the biopsy from the region which doesn't show me the cancer, so it might lead to my false negative results, is it? So that's the reason I will take the 3 or 4 smear. 3 or 4 or even 5 or 6 smears is are going to be seen. Get it? So that's going to be your, diagnosis for the prostate. And once the prostate is diagnosed, cancer is diagnosed, you use the chemo and the radiotherapy for that. Okay, so that was actually the prostate cancer for you guys. Now we are going to discuss the breast and its pathologies. Okay, so we're going to discuss the breast. First, we will discuss the benign conditions of breast. Then we will discuss your malignant conditions of the breast. So let's discuss the benign conditions of the breast. So first, we are going to discuss the inflammatory conditions of the breast. So inflammatory disorders of the breast. First, we are going to discuss your mastitis, especially that's called the lactational mastitis. So inflammatory processes is called your mastitis. So mastitis is defined as an inflammation of the breast is called mastitis. And what is the risk factor for mastitis? Why do we get the mastitis? The risk factor for mastitis is breastfeeding. So this is the reason your mastitis is also called as your lactational mastitis. So why breastfeeding is a risk factor? Because breastfeeding will create cracks in the skin, cracks in the skin, cracks in the nipple. And when there's a cracks in the nipple, what will happen? The bacteria can enter through these nipples. So what is the most common bacteria which can cause mastitis? It is called your Staph aureus. Very good. Staph aureus is there. That's going to cause your Staph aureus is the most common cause. Now, any female who get the mastitis, what are the symptoms of mastitis? Symptoms of mastitis. Yep. Symptoms of mastitis is exactly what? She's going to get what? She's going to get the swelling, redness, all signs of the inflammation. Swelling, redness, pain, and she might have the fever as well. Is it? Okay. So this will be the signs of your mastitis. Now, what's the complication of mastitis? Complication of mastitis, you might get the abscess, breast abscess. And once you get abscess, can anybody tell me what will the unique finding of the abscess? What will you get in the abscess? What's the unique finding of the abscess? Mhm. So it's going to lead to localized collection of the fluid. So you will get the erythema that will be localized to one site. Abscess means what? Wall of collection of the pus. So you will get what? Localized collection of the swelling. Localized swelling. So mastocytitis will lead to generalized swelling, whereas your abscess is going to lead to focal swelling of the breast. Got it? And how do you treat your mastocytitis? It's a Staph aureus infection. So how will you treat them? Yep. How do we treat?
Antibiotic.
Antibiotic.
Cephalaxin, no cephalaxin, but for the Staph aureus, what antibiotic we use? Nephicillin, oxycillin. Is it nephicillin, oxycillin could be used if it is not a MRSA being there. Hopefully, this is not a MRSA. If it is MRSA, then we use the vancomycin. Is it? So nephicillin, oxycillin, and plus continue the breastfeeding because breastfeeding is going to wash out the breast. Is it? So it will wash out the infection, wash out the pus. Okay. So that is called the mastocytitis for you. Now, other inflammatory breast disorder is called the fat necrosis. So why fat necrosis is very common in the breast? Fat necrosis means the damage of the lipids. When you get the damage of the lipids, it will lead to the fat necrosis. Now, fat necrosis is going to be, what is the most common? Why do we get the fat necrosis in the breast? The most common cause is trauma. And that trauma can be minor trauma as well. Even female does not know she had the trauma. So that could be minor trauma or major trauma. Minor or major. Is it? Major means it will be after road traffic accident. she might get the injury or the compression of the breast, which can cause the fat necrosis. Is it? So any female who get the fat necrosis, how she's going to present symptoms? Symptoms. Yep. What will be?
Usually painless.
Yeah, it's going to present as the painless lump. Painless lump. Painless lump. Painless lump will be seen at the injury site. At the injury site, you're going to see the painless lump because of the necrosis going on. Because of necrosis going on. So, in order to diagnose this, we have to do the mammography. Now, what will the mammography show me in case of fat necrosis? Mammography. Yes, mammography. If I do the memo, what will the memo show me? The memo is going to show me exactly, it is a fate. So, fate and the calcium, they both are seen together. So you are going to get the calcified oil cyst on the mammography. Calcified oil cyst, like cystic mass is going to be there. So you get what? Calcified oil cyst. Calcified oil cyst is going to be seen. Okay. All right, on the mammography, you're going to get calcified oil cysts. All right, and you will also see, so, when you see calcified oil cysts, still you have to confirm it. So you do the biopsy. And what will the biopsy show us? Yeah. Biopsy is going to show us the necrotic fat cells. Necrotic fat cells will be seen. That's very simple. So you are going to get what? Necrotic fat cells and the giant cells. Giant cells will be the macrophages. Okay. So you get necrotic fat cells, and giant cells. Got it? So that's going to be your diagnosis of the fat necrosis. Okay. All right. Now these were actually your inflammatory breast disorder. Now let's discuss one other disorder that's called gynecomastia. Gynecomastia. Now gynecomastia is defined as the enlargement of breast tissues in the male. Enlargement of the breast tissues in the male is called gynecomastia. Enlargement. So this enlargement could be due to what? Anyone who knows the answer? Enlargement of breast tissue in the males. In the males. So normally males does not get the enlargement of the breast. The reason is that because testosterone prevents the growth of the breast. So that is because of the estro. Very good, Leila. That's actually due to your estrogen, increased estrogen. So when you get increased estrogen will actually lead to increased growth of the breast, is it? So it means increase estrogen to testosterone ratio. This ratio will increase only when your testosterone decreases and estrogen increases. That ratio is going to be increased. So we measure this ratio to see the development of the breast in the males. Now, any pathology which increases estrogen will lead to gynecomastia, or any pathology which decreases testosterone will lead to gynecomastia. So there are two types of gynecomastia. One is called physiologic gynecomastia, physiologic. Another will be called pathologic. So physiologic gynecomastia means what are the conditions which are actually physiologic, not a pathologic, which will lead to increased estrogen in the males, especially at the time of puberty. So when the male who reaches to the puberty, he has a lot of the estrogen in the blood. So that's called pubertal gynecomastia. So pubertal gynecomastia is actually normal. So if you see gynecomastia in a patient between 10 to 15 years, 10 to 15 years, you have to reassure the patient. So, a lot of the patients will present that they get actually bothered by the development of the breast, but you have to reassure them and have to ask them, wait and watch, it will regress by itself. So, puberty is there, and other cause of the physiologic gynecomastia is a newborn. You know why newborns? Because newborns might get the lot of the estrogen from the mother. The estrogen will go from the mother, and that's going to lead to the enlargement. That's going to lead to the enlargement of the breast. Is it? So newborns can be there, and other is the older males. When you get older, the metabolism of estrogen is very slow. Estrogen is not inactivated, so that will lead to the gynecomastia. So these are the three causes of the physiologic gynecomastia. Now we have the pathologic gynecomastia. So what are the pathologies which are going to increase the estrogens? Yep. Anyone? On the top, it should be cirrhosis.
Liver cirrhosis.
Very good. Cirrhosis can be there because cirrhosis will decrease the metabolism of the estrogen, so you get increased blood level of the estrogen. Excellent. What else?
Klinefelter syndrome.
Klinefelter syndrome. Very good. So Klinefelter syndrome will do what? It will increase the estrogen or decrease the testosterone.
Will decrease the
Decrease
testosterone.
the testosterone.
Because it leads to damage to the testes. Okay. Klinefelter. Very good. Decrease the testes. All right. All right. So what are the drugs which will actually lead to the gynecomastia? Favorite drug?
Spironolactone.
Excellent. Anti-androgen, which blocks the aldosterone receptor. Very good. So any patient who get the gynecomastia on the spironolactone, so you will switch this patient to what diuretic?
Cimetidine too.
That's cimetidine. My question is
Abiraterone.
epilerone. Very good. Epilerone. No, looplela. Epilerone. Because epilerone also blocks the aldosterone receptor, and I have to block the aldosterone receptor in this patient. So I will switch to the epilerone. Okay. Epilerone can be there. Okay. All right. So other could be testicular tumor, which produce a lot of the estrogen. Okay. Don't be sorry, please. Okay. You guys are trying, and I really appreciate that because when you try, you will learn a lot. Okay. This is what learning is. Okay, so apelurone is actually there. Apelurone, okay. All right. So testicular tumors can be there. Sertoli Leydig cell tumor, which will produce a lot of the estrogen that will lead to gynecomastia. And gynecomastia can be also seen in the obesity, obese males, because all the estrogen will be converted. Get it? And now breast pathologies are remaining. You guys do have the UWorld class today? Is it?
Yes.
Yeah, ketoconazole is there. Okay. So I think we have to finish it here. Like only drugs are remaining in the breast. So I will actually try to complete it tomorrow. But tomorrow I'm not sure because I will let you know. I will be in touch with you guys in the group. I'm not sure we do have the class tomorrow or not. I will be in touch with you. Hopefully we will do a class. If not, I will actually may tell you in the group. Okay. I will inform you guys at the group. Okay. Anybody have any question, any confusions? Everything good?
Doctor, I have a small request.
Yeah.
If I don't know if everyone will agree with that. The missing two recordings, we'll go through them ourselves because I missed them. If it's possible to just
Yeah. We will
summarize the placental disorders and the mole. These two were
yeah, hopefully in the boot camps we will go through them. Don't worry. Okay.
okay. All
Yeah,
right.
don't worry, don't worry, don't
Mhm.
worry. Because
Okay, thank you.
I realized that these are actually high yield one and I missed the video.
Yeah, and actually you explained very well. So you know the topics you explained, we actually remember them. So this is why I
Yeah,
wanted if it's possible. Yeah.
I'll do it, don't worry. So our
Okay.
focus, tomorrow your focus should be on the reproductive drugs, OCPs and intrauterine devices. So that will be high yield.
Mhm.
And hopefully we do it tomorrow and tomorrow I will complete the repro. Okay, don't worry.
Okay. Thank you.
No problem. Okay. Just if I have the off tomorrow, just go and catch up all these videos. If in case I'm off. If not, then we will do it. I will actually inform you guys early. Okay. All right. Thank you for coming and I see you guys tomorrow, hopefully. Bye bye. Take care.